So I want to introduce Paul Estabrooks. He's a professor of health and kinesiology and associate dean for community engagement in the College of Health at the University of Utah. And hopefully he'll define kinesiology for us, I hope. Paul's a unique character, and this is why we chose him as our keynote speaker. He really helps us bridge that gap between public health, impact of public health, and the impact of science that drives that. And he does that through community engaged work, through system level approaches to really integrate health promotion and disease prevention in community, corporate, and clinical settings. He grounds his work in dissemination implementation science, and he uses, I think, really shows us how to use that science to really advance public health. He's an investigator on multiple different projects. He's truly a scientist in that setting, in that you can say, well, when I was early in my training, my boss used to say to me, focus, 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 Mario. But I refused to do that. I wanted to do multiple things. And Paul accomplished that as well. That's true. He's working on projects on obesity prevention among American Indians. He's built sustainable referral pathways for family-centered health weight programs and integrated physical activity in these mobile health units to go out into the field. In addition, he's doing work in genomic medicine, really resonates here for our colleagues here at Children's Mercy, doing work on integrating social determinants in tobacco cessation, and looking also at helping implement brain injury screening in organizations that serve women experiencing partner violence. That's pretty diverse background. So I'm excited because he is taking this model. He's going to show us how to take these models we use in implementation science. You're going to hear these words later on, I'm sure. PRISM, IPARIS, CFER, and the REAIM framework. And Paul has really led that to a number of works. He's published over 300 peer-reviewed papers. He really bridges that gap between research and practice. And he's led national and international workshops on this REAIM framework. So hopefully one take-home skill that you will develop today will be really to understand this framework and how it's applied to advance public health. So we're excited about having Paul today as our keynote speaker and to launch what we think is a very exciting symposium. Thank you, Paul.
All right, thanks for that very nice introduction. I'm excited to be here. It's wonderful to see you guys in the front row. I also have a high schooler at home who is a freshman, and we have high school research assistants that work in our lab, and we've had a lot of great success with that, so it's exciting to see you guys here, and hopefully you get to meet with folks and talk with folks and look for opportunities for yourselves to engage in science early. So thank you, and thanks for coming. So I think I was supposed to have a 45-minute talk. I ran through it this morning and it was 55 minutes, and now I only have 40 minutes. So I'm gonna make some changes on the fly. So it'll be a bit of jazz here, but some of the nice stuff is that Dr. Leader and Dr. Castro actually gave some of the points that I would have started on that first slide. So I'm gonna move to just an example here. This is a slide that I got from my colleague here at KUMC, Dr. Anna Gorshika, and I knew I was going to get her name wrong the first time, but I got it right, I think, the second time. But she provided me this slide that she's used to demonstrate one of the issues that we have in science, and it's that we have evidence very early on, but it takes a very, very long time for it actually to get to people and help people. And so if you look up here in 96 to 2002, NIH funded a multi-center trial to test the ability of lifestyle change interventions to delay the onset of diabetes. and it was very successful. In 2002, that work was published, and it demonstrated that lifestyle interventions can effectively reduce incidence or progression into diabetes by 58%. So really, really good outcomes. By 2008, the YMCA had developed a model where they could potentially deliver this type of intervention, and in fact, they started to do studies on how they might deliver it. In 2010, the CDC took all of the stuff that was developed in the 2002 study, packaged it up so that communities could take the package and be able to be trained up and lead this program in their communities. So really good stuff there. In 2016, the Centers for Medicaid and Medicare Services funded a lot of pilot studies to see if there was cost effectiveness of this type of approach. They found that it was. And in 2018, it became a reimbursable service. So people could deliver it and actually get reimbursements like we do with other healthcare treatments. All great stuff. By 2019, and this is a little old data, but it's still not much better than that. By 2018, only 0.4%, not 4%, only 0.4% of the people who could benefit from diabetes prevention programs engaged in that type of program or had opportunities and access to those programs. So if you look at that and you start doing the math, we're 2002 to 2019, that's the 17-year gap we talk a lot about in implementation science, where 14% of the evidence that we generate is moved into some sort of action after 17 years. How many of you guys are 17? Oh yeah, how many are younger than 17? Okay, so we know a whole bunch of stuff that we knew when you were babies that still haven't gotten to people, right? So that's one of the issues that we have in science. And so we end up, for also those who know dissemination implementation science, we love our frameworks, our theories, our models and frameworks. And so when a field runs into the same obstacle, and this is not really a new obstacle, but we have this obstacle that evidence exists, it's hard to find, it's hard to compare across different types of studies that we've done, and then it's hard to generalize that research from the research study into communities where it could ultimately do good. And so there's a couple of schools of thought that tried to develop frameworks to address this. How many people have heard of the PICO framework? Raise your hand. Yeah, good. A lot of times we come into here and people don't know anything about D&I frameworks, but they know about PICO because it was initially designed for evidence-based medicine. And the idea was that if we can, with our evidence as we're doing studies, do a really nice job of consistently defining the patient population that we're working with, the intervention that we're delivering and its characteristics, the comparisons that we're making, the comparison or control groups, and the outcomes that we're measuring and how we're measuring them, then we can start to compare across studies and be able to synthesize literature and advance our science. And so this is a really good framework for synthesizing literature to know what things are efficacious, what interventions are efficacious. Excuse me. And so at the same time, or a little bit earlier even, there is another group of folks that are working on what they call the causal inference approach. And what that means, sorry, wrong pipe there. What that means is that they're very interested in understanding if we do an intervention, why does it work? What's the causal pathway? What are the mechanisms? Kind of like if you drive a car, what are the things that are going on inside the car that make it work, they make it run? And so with this group, they had a slightly different framework to organize. How many people have heard of UTOS? None of you, because you're not from a social science background like me, because this is where I come from. I come from this tradition. And it probably wouldn't be very surprising that I come from this decision, because our framework focuses on who was studied, so similar to that patient's, treatments, very similar to the intervention and comparisons, outcomes, very similar again. But the difference here is, where did it happen? And so really with this kind of approach, people were very interested in the context within which research was done. And so external validity, how does this generalize out of the research study and into communities or into clinics? And so where these two things ended up merging is it shifted us away from a science that's just focused on, does it work, to, does it work for who, and under what conditions. Okay, so that's really, and this is the groundwork. This is where we come to dissemination and implementation science. Okay, so what is it? Here is a definition that I like to use. It's the scientific study of the strategies and mechanisms by which scientific evidence is disseminated and implemented in community or clinical settings to improve outcomes for a specified population. And so I've bolded some words there that I'm going to keep hitting on as we go through the talk. I'm going to skip over these two for time and then tell you that the spin that I have, so you saw in my title, Community Engaged Dissemination Implementation Science, is a very similar type of definition that I won't read for word from the screen here, but really what the type of work that I do is that we work with the community, and communities broadly defined can include healthcare systems, can include, as Mario talked about, one of our projects, community-based organizations that provide services for women in need in time of crisis. So it can be any type of partner, but we do this type of science in partnership, in collaboration with and for the communities where the evidence will have the most benefit. Okay? So that's community engaged dissemination implementation science. So as I said earlier, dissemination implementation science in general really likes theories, models, and frameworks. I think that at last count we're at about 113 different theories, models, and frameworks that have been proposed, which one of my previous mentors would have said means we really don't have any theories because we haven't tested things out well enough to start to eliminate and move towards the things that actually are predicting and helping us to understand how dissemination and implementation occur. And so even though we have a lot of theories, models, and frameworks that are very, very helpful and have been impactful, the problem with all of that theory noise is it also presents an obstacle where it becomes overwhelming for people even to pick, like, what theory should I use? How should I go about doing this? What measures should I use? So a lot of issues related to that. And so when you're thinking about it, and I do want to highlight the different types, we have models that we think about as process models. And so what that means is it gives you step by step, how do I do the implementation science, and how do I do the implementation, and how do I do evaluation to determine whether what we're studying should be sustained, terminated, or adapted and tried again. Okay? Then we have another set of models that are focused on outcomes. And as Mario said, I focus a lot on the REAIM framework, which includes the reach of our evidence, its effectiveness, the adoptability in different community and clinical settings, its implementation quality, and its ability to be maintained in those systems. And then if you, I'll just stick with that for now. And then finally, we have more of what are traditional kind of determinant theories or explanatory models. These theories give you a lot of lists of concepts that they think would be related to either reach, adoption, implementation, or maintenance. All of it started with diffusions of innovations. At least this is my theoretical approach. How many people have heard of this one? Okay, great. And it's a really well-known theory. I also have a project that I collaborate with a professor in communication, and when I tell him it's a dissemination implementation science theory, he gets cranky with me and says, no, it's a communication theory, because it's really influenced a lot of different fields. But the idea for diffusions of innovations is that you have an innovation, and in our world, in translational science, we usually think about that as an evidence-based intervention, so something that has some scientific testing to demonstrate that it has efficacy or effectiveness. So we have an innovation that travels through a social system based upon its communication channels over time. Okay, pretty straightforward. That's what diffusion of innovation theory is. This is the foundation of every other explanatory theory that we have in dissemination and implementation science, every other one of them. And I'll walk through a few of them because since Mario said the names of them, I thought I'd better say the names of them too. So here's the IPARIS framework, the Integrated Promoting Action on Research and Health Services. That turned out a little blurry up on the big screen. Don't worry about all of the constructs. But what this theory did, and I'm presenting these in order of publication, so when they came into being. Okay, so with this one, it took that diffusion of innovation, has a lot of the concepts, but really built out the facilitation features around the communications channels, and says this is the key ingredient of successful implementation, it's facilitation. And so then what came out next was the practical and robust implementation and sustainability model. And this one, if you look closely at it, where it really did a nice job is it took that social system, and the red box at the top, you can see it talks about the multi-level sector perspectives about the evidence-based intervention, the external environment that can put pressure on a social system, the people in that system, so multi-levels of the beneficiaries, the implementers, the administrators, and decision makers, and then the actual infrastructure within which the intervention can be delivered. And so it really did a nice job of kind of expanding that social system and then trying to link it to outcomes. So it's one of the first models that tied in outcomes with their framework. The consolidated framework for implementation research was the next one that was published. This one is a really, really great theory, and it started as something called a meta-theory. Do you guys know what a meta-theory is on the front row? A meta-theory is something where you just pull a whole bunch of ideas together and you say, here's a bunch of things that we think are important, but then you don't provide hypotheses on how they interrelate with one another. And so that's one of the things that's very consistent with a number of our determinants theories is that it provides us with lists. But what the acronym that we go with this is CFER. What it did really nicely is it added that little green arrow of processes. Again, trying to build upon communication channels and structures within the social system to start to think about, well, what are the actual processes that can lead to better implementation? And then finally, this is the last theory that I'll introduce here very quickly, is the EPIS framework, which is exploration, preparation, implementation, and sustainment. This one, you might have noticed, really focuses on time. So the time aspect of that diffusion of innovations. So when I look at these theories, models, and frameworks, I tend to pick the one in a given project that best fits the idea that we're trying to change. So if we're trying to improve something like adoption, which is the first time that someone would take an evidence-based intervention and put it into action, I might think about EPIS because it has a lot of opportunity for me to think about the exploration and preparation prior to the implementation of an evidence-based intervention. In many of our projects, we use facilitation as a key implementation strategy. In those projects, we tend to use the IPARIS framework because it does a really nice job operationalizing that construct. So one of the things that I've kind of touched upon here a little bit as I've gone through is that while these theories, models, and frameworks give us a lot of opportunity to learn, there's also some problems with having that many. Sometimes the theories use the same concept but call it different things. Or sometimes they use different concepts and call it the same thing. And so then if we start publishing things around this, it becomes very confusing in the body of literature about what the actual advances are. And so what we don't do really well with our theories is say, you know, here's what the theory is, here's where our strategies fit within that theory, here's the mechanisms of action of those strategies and the outcomes that can occur. And so we wanted to, or in the field in general, wanting to better do some of that mapping. And this is another figure that I borrowed from Dr. Gorsica. Again, a little bit blurry up there, but it's not intended for you really to read it. But this is the implementation research logic model. So yet another model in dissemination implementation science that was developed by a colleague of mine, J.D. Smith, and some of his colleagues at the University of Utah. But the idea here was what they wanted to do was say, okay, how can we map some of this stuff? How can we think about the determinants, strategies, mechanisms, and outcomes? And they put this framework together that helps people to do this mapping. One of the things that we've discovered using this over the last 6 or 7 years is that a lot of times the column on on your left and the mechanisms column end up being redundant to one another. So we might say, oh, you know, the determinant is that our staff doesn't have capacity to deliver this intervention. And so because of that, we're going to pick a strategy that is training. And then that training strategy is going to work to improve implementation of our intervention by improving capacity. So it ends up being a little bit circular. And so what we started to figure out is in our theories, models, and frameworks, a lot of times we have concepts that are contextual factors that may be not changeable, or at the very least aren't targeted by our strategies. And then we might also have concepts that are in those theories that are the actual things that our strategies are intending to change that then lead to the outcomes, so the causal mechanisms. And so we introduced this idea, and we don't call it a theory, a model, or a framework, we call it a heuristic, just so we don't get in trouble and people say, yeah, no, they're just doing the same thing and making more models. But we started with this thing that we call Cosmos, which is just replacing that determinants with a term context, and then really trying to better tease apart what is a contextual factor and what is a mechanistic factor. And we actually did with some of my doctoral students a couple of years ago, or about a year ago, we did a survey of about 70 implementation scientists. And these folks self-identified as either beginner, intermediate, or expert. And we had about a third of each of those groups in there. And we asked them to define for us what context is. And so the folks that self-identified as beginners, they defined context as where the work is occurring, where we're trying to do implementation, which I think is exactly right? That seems very appropriate. That's where it is. That's our context. If you think about the intermediate folks, they advanced it a little bit and said, well, yes, it's that, but we really want to outline that it's the setting, it's the available resources, the people, the regulations, policy, and anything that could support or impede implementation. So that gets a little bit more specific. And then experts kind of even took it up a little bit further and started thinking more about multi-leveled factors, including things like policy, history, and relationships, where we start to get into things like structural racism as something that could be a big contextual factor that is unlikely for our strategy typically to change that big systemic approach, but it tells us about the types of strategies we need to put into those types of structures to try and alleviate the burden that they provide on people as they try and promote health. So I'm not going to go through definitions from each level of groups there, but I thought that it's nice to kind of think through context. And so context, the way that I think about it in our science, is usually stuff that is immutable, or that's a terrible word to use, but unchangeable, things that are kind of fixed, that with my strategy, it is highly unlikely that I can change. So I want to try and match a strategy that fits there. So it could be something about workforce size, or workforce expertise. So we know who the folks are that are delivering an intervention or could potentially deliver an intervention. So we're going to develop strategies that are tailored to that population. We're not going to try and change who they are, or how many people there are, or how many resources that are put into the system. But a strategy is an intentional action that's trying to facilitate change. And so that one I think is pretty straightforward. Sometimes my students get a little hung up on the distinction between context and mechanisms, and this is where we try and spend most of our time. The mechanisms are intended to be the things that are changeable. So as I said earlier, worker capacity is a really good mechanism. You can have low capacity, you can develop strategies that intentionally target increases in capacity, and that becomes the mechanism that you're working through to improve implementation quality. And then from an outcome perspective, again, we highlight the REAIM framework. You'll see three additional outcomes there that are appropriateness, feasibility, and acceptability. Those come from the Proctor Implementation Outcomes Framework. In our work, we don't consider those outcomes. We consider those mechanisms. So our strategies many times are trying to improve the appropriateness of an intervention for a given setting, its feasibility, and its acceptability within those settings. And those perceptions from multi-level, the decision makers and the doers within systems can influence the reach of an intervention, its adoption, its implementation, and its maintenance. Okay, so when I do the work that I do with communities and with clinical partners, the first thing that we identify is the priority. And what is a priority usually described as? It's the outcome. What do we want to see at the end of what we're done? What is the thing that we're trying to do here? And so we think about what outcome do we want to change, and then what's an appropriate strategy to change that outcome? And so for us, this is one of our projects that we've done previously. BHF is Building Healthy Families, a family healthy weight program developed and delivered with and for rural communities. And we want to increase the uptake. We want to increase the number of communities that deliver that program. And so then our next question is, if we're thinking about strategies to improve adoption, what is it about the context or the rural communities that we want to work with that would make this an interesting or important or prioritized outcome? Well, in this case, the context when we did this study was that most communities in rural areas, and this was in Nebraska we did this work, had identified in their community health improvement plans, the CHIPs, childhood obesity as a priority. And so because communities have that as a priority, and we have an outcome of a program that could address that priority, the type of strategy that we choose could be something as simple as a fund and contract strategy. And what that means is just doing a request for applications, providing a little bit of startup funding for communities, and giving them the resources necessary to be able to deliver the program. Because they have a priority, that type of strategy works really well because all we're doing is increasing the opportunity for them to change the mechanisms within the system. And one of the things that we do with our research, with our request for applications, is have communities work with a partner that can do recruitment for the program and a partner that can do delivery of the program. Pretty simple. So we really support this idea of network weaving in those communities. And by doing that, we end up increasing the collective efficacy of the community to deliver a program like this, and we increase cross-system collaboration, which we think is the causal mechanisms of increasing the adoption of building healthy families. So that's in a nutshell, Cosmos. So now I'm gonna try and go through, let's see, you said I could go till 10, right, Julius? Okay. And then everyone has to hustle, like walk briskly, which is good because that's a really good public health behavior. Yeah. And 5 minutes counts. Any minutes of that counts, so good. Okay, so I'm gonna talk to you about one of our newer projects for our Prevention Research Center and what we did with it. I'm gonna start by the more traditional, what is the study? And then I'm gonna go through the Cosmos mapping. So for this particular project, what we want to do is we want to help communities develop capacity to address childhood obesity through building healthy families, our evidence-based intervention. And we want to do that by a few different things to help communities get that started. But one of the things that we found in our early studies that in rural communities in particular, but I will tell you, I don't know if Ann Davis is here or Christy Beffert, some great researchers here who have done rural work. Reach is a real challenge, getting the people into the program, right? So that's a real challenge. And so what we wanted to try and understand is how do we identify, invite, enroll, and then engage over time participants in building healthy families. That's what our study is basically about. We start with a population health management approach where we would work with rural clinics to identify families that are available, or not available, eligible to participate. We then do an automated patient outreach through text messaging. And then this is where our study starts, really. We start the study to give folks an opportunity for self-enrollment in the programs via just a single opportunity. We send them one text from their provider so they know, and we work with our provider and patient advisory groups to figure out the language, how we best present this, how it comes through so that people aren't just gonna hit the report junk and not use it. So we have some really good work that we did on developing these, but just a single, we'll send, some of the families will be randomly assigned to just get one text message with an opportunity to join. And then another group of folks will be randomly assigned to that single text message, and then the community implementation team will follow up with a telephone call or text outreach to engage them. And then the next group of folks will be randomly assigned to getting repeated opportunities once a month over 3 months, because families' motivation can change over time. So one of our mechanisms is that motivational readiness is improved by having repeated attempts to give folks opportunities. And we have another study that looks at blast text messages versus this monthly thing to know how much do you piss them off if you send too many texts at a time versus how many, like what's the optimization of that. This is not what we're doing here. Or we would give folks a repeated opportunity for enrollment. And so these are the 4 conditions that we're studying. Our primary outcome is enrollment, the number and proportion of families that were eligible in a given community that enroll in building healthy families. We have a sequential randomization that enrolled families then are further enrolled into text message support that's either just kind of daily reminders or motivational messages. And the intention here is to look at the attendance in the program over the 12-month period of program implementation. Okay, everybody feel like you got that study? Now you know what this study is. This is traditionally how we would present this type of study in a grant. Very quick, you can look at it, you can get a good sense of what's going on. But where was all that Cosmos stuff that I was talking about before, right? Like where is all that? Because we did all of the Cosmos mapping before we came up with what the final design would be. So I'm going to show you that. Again, we used the IPARIS framework that I'm not going to dive into a lot of detail on. But for this particular project, there's our contextual factor. We thought, well, one of the things that we could do is we could help community organizations and clinics develop a really easy way to collaborate so that they could develop a sustainable pipeline of referrals for a local program. A very simple, practical question that we want to answer. And so that's where we went with the population health management approach. We think that it'll work because it'll increase family awareness of building healthy families, it improves systems integration, and it would make it easier for families to enroll in the program. Right? So pretty straightforward mechanisms, and we think that those would improve the reach of the program. You can see our purple here are the random assignment categories. So these are the things that are associated with our primary aim, which is, the follow-up, if you have follow-up or not. The mechanisms here are that we get clinic community coordination, and again, it's ease of enrollment. I repeat the mechanisms in different boxes because otherwise our lines get all crazy, as you'll see with one of the other examples a little bit later on. And that also is intended to increase reach, our repeated opportunities. And I'm not going to keep going through all of the mechanisms, but in essence, this is our study. But if you're doing community-engaged dissemination and implementation science, there's a whole bunch of other things you got to be thinking about. Like, how do we make sure that this program can be adopted in these communities? How do we make sure this program can be implemented with high quality? And ultimately, how can we make sure the community has the capacity to sustain this type of program once the research is done? Because we're not just interested in the research, we're also interested in community impact and having a sustainable community impact through the research that we do in real time. And so again, I'm not going to go through all of these, but as we work on this as a team, we come up with a lot of different strategies. And so when you think about our project, yes, you can think about just that line and the path, but in order to be able to just test that question on reach, there's a whole bunch of other contextual factors, strategies, mechanisms, and outcomes that we need to be thinking about so we make sure the whole thing works as a system and it's not just about text messaging. Okay. So I'm going to do a little bit different approach here. 9 minutes, I think we're pretty good. This is for those who are part of your Frontiers CTSI. Do you guys call it a CTSI or CTSA? I. Okay, good. That's what I've been calling it, and then all of a sudden I thought I heard someone saying A. So, okay, it's award. The award is what you get. The institute is what you operationalize. So with the Utah CTSI, I collaborated with our director for the Center for Genomic Medicine, and we developed a project, and it was with the RC2 mechanism. And so for those who are interested in RC2, it's changed a little bit. I know you guys are getting ready to do your UM1 application again, but I believe we were the only RC2 that was funded in the first round. And there's a lot of different reasons why we think that was. So if folks are interested in that, I'm not going to talk in depth about that part of it, but I'm happy to talk through it. In this one, we actually used two different theoretical approaches. We used PRISM and IPARIS, and the one of the things that we want to do here is actually compare and see, is there utility of one over the other, and are there things that we can start to do to narrow down the number of theories, models, and frameworks that we have. And so I'm going to give you the quick goal of the study, that I'm just going to let you take that in cognitively rather than read through it just for time. But basically what we're trying to do is come up with ways to, maybe I'll go to the timeline slide here, ways to improve rapid whole of genome sequencing. That is not what I do. That's what my collaborator does. That's why team science approaches are so important. So we want to first see, can we make this better at identifying rare and unknown conditions for families with kids in the NICU where they're struggling and we don't know what's going on, right? So we want to get better at that. But we already know rapid whole of genome sequencing is pretty good. And so then the next thing we want to know is, well, if we know that, how do we integrate that into our health system, and in particular into our bioinformatics infrastructure, to be able to make sure that information can be shared quickly and clearly amongst the providers who are in the NICU that would use this information and help families. And then for us, what we're very interested in is what's the family experience and how has the current implementation of whole of genome sequencing affected those families, both in a positive way as well as in less than positive ways. And then ultimately what we hope to create with this, and we're about 3 years into this project, so we're quite a late ways along, is an implementation blueprint that would allow the optimization of rapid whole of genome sequencing in NICU units across different types of hospital systems. Okay, I'm going to skip that one. And I'm going to skip this one. We do have an implementation research logic model. If you want this, I can email it to you. But I really wanted to talk through our process for this one. So we really used a lot of interest holder engagement with this, and we focused on parents who had been in the NICU and had a child that needed rapid whole of genome sequencing, which sitting in on some of those advisory panel meetings, you just are amazed with the resiliency of parents in the face of very, very challenging times where you could have whole of genome sequencing done and have a path forward, but many times, even with that sequencing, there is no therapy, no things that can be done in response to it. So the parents that we've engaged with have just been wonderful partners and just provided a whole bunch of really valuable information for improving the implementation of this approach. And so we start with caregivers. We think about the people in the NICU who are delivering care, and then we think about the technology that supports the NICU, and then we think about the administrative decision makers that oversee what things can be done in the NICU. So we have a whole bunch of different interest holder groups that we work with. And we started with a workflow analysis, which this is, and again, you're not intended to be able to read this, it's just to give a little bit of a sense of complexity. This is the first workflow analysis from the time a parent and a kiddo get into the NICU to the time they leave, with whatever the resolution is after rapid whole of genome sequencing. This was done by the folks at the Genomic Research Center and the providers on our team. And so then we said, great, we've got that. Now we're going to go and we're going to talk to the people in the NICU and ask them about the workflow. And so then this is what we got. So a whole bunch of stuff we don't know, right? Oh man, there's a lot of things going on. And then trying to map this stuff to say, what happens when? And we realized that we needed, again, some sort of concept to help us. And so we started thinking about time by role, by activity. And again, you don't need to be able to read this, but this is our final workflow. And so we're able to work together, and we did this through direct observation in the NICU. We did this through daily interviews of providers that were very quick and easy for them to be able to complete. We did this through actual advisory panels that we did in the evening when folks could come and engage with us. So this was really helpful to set the stage for context mapping, right? So where are the places on this workflow that we're having issues? Where are there times that parents aren't satisfied with the information they're receiving? Where are the times where there's gaps and frustration for providers? Where are there places where there's interpretability despite having the whole of genome sequencing completed? And so all of these things, all of this workflow gives us an opportunity to map through those contextual factors. And we followed this workflow analysis with something called comprehensive participatory planning and evaluation with all of those interest holder groups. And we just basically asked the questions based upon the workflow, what's going right, what's going wrong, and how can we improve? And so I'm gonna keep, oh my gosh, I got a whole nother example, you guys. So I think we're probably not gonna get to if you wanna hear about the wellness bus, we'll do it another time. But one of the things that has been so valuable with this process is that and this is only one example of a strategy, but we've been able to collapse down the parent barriers that they experience in this context, the provider barriers, and the administrator and technical barriers that are encountered. And then together with those groups, we identify strategies that can address all of those barriers. And so to bring this back to our cosmos, what this ends up being is that some of the strategies that we design are just based upon the system that we have. So how does it best fit within Epic? Because that's the electronic health record system that we have. But others of them are mechanisms where the barriers are actually a breakdown in communication. So if we build strategies to improve communication improves the patient experience, the caregiver experience in the NICU, which then improves overall quality of life for everybody that's involved. Okay, and then our implementation blueprint. Okay, I am just gonna, this is the one that I'm most excited about right at the moment because it's relatively new and we've just got our first cohort of data, but we have started to integrate exercise as medicine. How many people have heard of exercise as medicine in the room? Okay, good, a few folks. Into a mobile health unit. And yeah, I'm not going to jump, I'm gonna just give you cognitively, you can look at these images and take in this information and we will move through and hopefully you will get things. The bottom line is that when we did some pilot work with the Wellness Bus, a local mobile health unit that provides services for about 1,500 low income, primarily Hispanic, Latino, primarily uninsured populations in the West Valley, in the west side of Salt Lake Valley, we found that about 70% of them were not meeting physical activity guidelines. And that was the highest public health lifestyle behavior discrepancy in terms of meeting versus not meeting guidelines that were there. And so we decided as a group in partnership with all of the groups that you see up on here, how are we going to address this issue? And that's where the exercise as medicine idea came in. I'm going to look at all the building work that I did on these slides, you guys. Isn't this great? Like, you guys could just take it in. I will share them. Everybody can have a look at them. But the thing that I really wanted to walk through on this one, and if you come to the workshop, we can talk a little bit more about this because we'll talk a lot about mapping. And if that completely turns you off, don't come to the workshop. Okay, that's easy. But yeah, and so we ended up coming up with a number of strategies that really focused primarily on reach, adoption, implementation, maintenance, and then of course we used a group dynamics-based physical activity program that was an adaptation by the group. Yeah, and so so this is why I break it down one at a time, because if you show the whole model at once, it's all like, what goes where? But all of this planning ends up leading to some really good things. So this was our first cohort that we went through. You can see, and the really good thing is that we utilized health and kinesiology students. For Mario, kinesiology is the study of human movement. There you go. So now you know the definition. They have a practicum at the end of their degree that they have to go out into the community and deliver programming. So we integrated into that class structure one option for students to engage with the Wellness Bus. We're on our 5th cohort. It's the most we have to now select applicants from the students to do this. But it's a sustainable model. There's new students every semester that can continue to deliver programming. And so it's worked really well. They deliver it really well. We use qualitative approaches to try and, excuse me, assess our mechanisms. You can see some of the bolded words there are the mechanisms that we had both hypothesized and some that came through in our qualitative work. And so, what do all three of these projects have in common? Because we talked about childhood obesity treatment in rural areas, physical activity programming with a wellness bus, and rapid whole genome sequencing in the NICU. And even though we have a lot of different settings here, the thing that we find consistent that is helpful in trying to improve the impact of all of these organizational services is that we shape our strategies to fit the context. And once we do that, we can be very intentional about what the strategy is trying to change in terms of the outcome, as well as the mechanisms by which it leads to those outcomes. And then those outcomes should include both implementation, I think, and public health types of outcomes. So we should be thinking about things like reach, adoption, implementation, and maintenance, our implementation outcomes, but we shouldn't forget about effectiveness, because oftentimes when we transition our work from scientific evidence, from different settings to new settings, the effectiveness isn't the same. And so we do want to continue to look at those things. There's also a historic arc that you can see across this work that really does tie a lot of translational science together in terms of how things have worked and how each one of these different approaches hopefully advances our science, with the cosmos really being focused on, yes, generalizability, yes, effectiveness, but also causality. If this stuff works, why does it work? And so if it stops working, we can test it out and figure out how to improve it because we know the mechanisms by which it works. Take-home points. Translation is a design problem. It's not something we should just do our research and then say, okay, we're done our research, now it's time to be translated. We should be thinking about translation from the generation of every piece of the research, from basic science all the way through public health science. Context isn't just noise. It's not just the place in which you're doing your work. It also provides you with opportunities to be planful and identify strategies that will be most effective in improving implementation success. And then, I didn't really beat the drum on this, but you can't do this kind of science sitting in your office, typing on your computer, or working in your wet lab. You have to be out and understanding the systems where you think that your work will have an impact or have some relevance. And in fact, by doing that, we end up having work that is much more relevant and much more likely to be adopted, implemented, sustained, scaled up across community and clinical settings. So I had just a few final thoughts, but I think I will just leave the slide there since it's now 10:05 and you are only going to get some high intensity training now. Like high intensity interval training, also very good from a public health perspective. That's right, exercise is medicine. Thank you.
Thank you, Paul. As he said, exercise is medicine, so please, high knees, everyone. If you're able to take the stairs, please use them to slow down traffic on the elevator. If you're staying in here for Dr. Olagoki's presentation, please scoot to the forward for her, please. Thank you. AO's coming up, and I think that's it for now. Thank you, everyone. Thank you, Paul.